Welcome to KJR SummaryCast, audio summaries of peer-reviewed articles published in the Korean Journal of Radiology. Designed to enhance reader convenience and the overall KJR experience, SummaryCast provides conversational audio overviews for time-constrained listeners and mobile-friendly learning. This recording was created using a combination of AI tools with oversight from the KJR editorial team or the article's authors, including necessary edits and corrections. For the most accurate and complete information, we encourage you to also read the original published article.
Welcome to SummaryCast. Today, we are unpacking a study that challenges a pretty fundamental dogma in breast imaging.
Right, the idea that supplemental ultrasound is really only for dense breasts.
Exactly. That has been drilled into the workflow for years. If the mammogram is dense, heterogeneously, or extremely, you consider ultrasound to catch what the white-on-white effect hides. If it's non-dense, fatty, or scattered, you usually stop at the mammogram.
Because historically, the thinking is that mammography is sensitive enough in that fatty tissue. Why add cost and workflow complexity if you can already see everything?
But today's paper asks, can we really see everything? And specifically, does automated breast ultrasound, or ABUS, have a role in those non-dense breasts?
It's a fascinating pivot. We're looking at a paper titled Screening Outcomes of Supplemental Automated Breast Ultrasound in Women with Non-Dense Breasts Undergoing Mammography.
Published in the Korean Journal of Radiology, 2026.
The researchers here, led by Mi-Ri Kwon and colleagues from Kangbuk Samsung Hospital and Samson Medical Center, really wanted to quantify if we are missing cancers by skipping ultrasound in women with BI-RADS A and B density.
BI-RADS A being almost entirely fatty, and B being scattered fibroglandular density.
Precisely. And just to set the stage, the sensitivity of digital mammography in non-dense breasts is generally cited around 85 to 90%.
Which is good, much better than the 50 or 60% you might see in extremely dense breasts.
Good, but not perfect. That gap means there's still room for interval cancers, those nasty surprises that pop up between screenings. So, let's dive into the setup.
So who did they look at? This was a retrospective study, right?
Retrospective, yes. They pulled data from two major tertiary institutions in Korea between January 2020 and December 2023. They started with a massive pool of nearly 10,000 women.
But they had to filter for non-dense tissue.
Right. After excluding the dense breasts and those with insufficient follow-up, they landed on a study population of 1,683 women. And here's the key. These were asymptomatic screening cases.
1,683 women. That's a decent cohort. And how many screening exams?
They analyzed 2,904 pairs of digital mammography, or DM, plus ABUS.
Okay, pairs. So they could directly compare the performance of mammography alone versus mammography plus ABUS in the same patient at the same time.
Exactly. It's a paired comparison design. And they use the Invenia ABUS system from GE Healthcare, standard use, AP, lateral, medial.
And the readers, because with ultrasound, operator dependence is always the elephant in the room.
Well, that's the beauty of ABUS. The acquisition is standardized by the machine, but the interpretation was done by board-certified breast radiologists. They had a range of experience, 2 to 33 years.
And were they blinded?
They interpreted the mammograms independently, but importantly for the ABUS reading, they were not blinded to the mammogram results, which makes sense. That's how it works in the real world. You read the volume scan knowing what was on the X-ray.
Fair point. Simulation of clinical practice. So let's get to the numbers. What was the headline on cancer detection rate, the CDR?
The headline is positive but nuanced. Mammography alone detected 7.9 cancers per 1,000 examinations.
7.9 per 1,000. That's a respectable yield for a screening population.
It is, but when they added ABUS, that number crept up to 9.0 per 1,000.
So an incremental CDR of 1.1 per 1,000.
Right, 1.1 extra cancers found for every 1,000 women screened.
I have to say, 1.1 doesn't sound earth-shattering. In dense breast studies, we often see incremental yields of 2, 3, sometimes even 4 per 1,000.
True, the absolute gain is smaller than in dense tissue, but statistically it was significant. The p-value was less than 0.001.
Okay, so it's real, but is it impactful? Did it change sensitivity?
Significantly. Sensitivity went from 88.5% with mammography alone to a perfect 100% with ABUS plus mammography.
100% sensitivity? That triggers my skepticism alarm. Nothing in medicine is 100%.
I love the skepticism. In this specific cohort, they found 26 cancers total. Mammography missed 3 of them. ABIS found those 3, plus all the ones mammography saw.
Got it. So within the closed loop of the study, they didn't miss any cancers that were subsequently found by other means during the follow-up?
Correct. No interval cancers were recorded in the follow-up period.
Okay, so sensitivity is perfect, but usually when you add a modality like ultrasound, you pay a tax, and the tax is specificity.
The false positive tax, and they did pay it. Specificity dropped from 97.9% with mammography alone to 95.0% with the combination.
A nearly 3% drop. That means more women getting called back for findings that turn out to be nothing.
Exactly. The recall rate, or abnormal interpretation rate, doubled. It went from 2.9% to 5.8%.
Doubling the recalls? That's non-trivial. If you're running a high-volume center, doubling your recall rate is a massive logistical burden and a lot of anxiety for patients.
It is. However, the authors argue that 95% specificity is still quite high compared to handheld ultrasound studies, which often drag specificity down into the 80s.
That's a fair comparison. ABIS tends to be a bit more specific because you can review the volume offline without the pressure of live scanning. But let's drill down. You mentioned this was non-dense breasts, but that covers a spectrum.
This is the most critical part of the paper. They broke it down by BI-RADS categories, and the results were starkly different.
I'm guessing the almost entirely fatty group didn't get much help from ultrasound.
It got 0 help. In the 183 exams with almost entirely fatty breasts, ABIS detected exactly 0 additional cancers.
0?
The CDR was identical. 16.4 per 1,000 for mammography, 16.4 for the combo.
And sensitivity?
Also identical. 100% for both. Mammography saw everything.
So for fatty breasts, adding ABIS was purely a cost. It added scanning time, reading time, and probably some false positives, with no benefit.
Actually, the specificity drop in the fatty group was minor, 98.3% down to 97.2%. But you're right about the benefit. It wasn't there.
Okay, so that reinforces the current guideline. Don't ultrasound fatty breasts. But what about the scattered fibroglandular group, the BI-RADS B patients?
That's where the magic happened. This group made up the vast majority of the study, over 2,700 exams. In this group, the CDR jumped from 7.4 to 8.5.
So all the gains in the study came from the scattered density group?
Every single one. The sensitivity in the scattered group improved from 87% to 100%. Mammography was missing about 13% of the cancers in these women, and ABIS picked them up.
That's a really important distinction. There is a tendency to lump non-dense into one bucket, but scattered density still has enough tissue to hide a small malignancy.
It's the masking effect. Even a little bit of fibroglandular tissue can obscure a non-calcified mass. And that brings us to the cancers themselves. Based on what we know about ultrasound, what kind of tumors would you expect it to pick up?
Usually, ultrasound-only cancers are small, invasive, node-negative, the good cancers to catch early.
You nailed it. There were only 3 of them, so small n, but they were all invasive ductal carcinomas, all stage T1NO, no node involvement.
And their size?
Small. We're talking about a mean size of 1.0 centimeters for these T1 tumors. In one case, the ultrasound finding was a tiny 0.5 centimeter mass.
Wow, detecting a 0.5 centimeter finding that turns out to be invasive cancer in scattered density tissue, that's a genuine save.
It is. There's actually a great figure in the paper, figure 3. It shows a 42-year-old woman. On the mammogram, there's scattered density, but frankly, it looks benign. You don't see a distinct mass.
And on the ABIS?
Clear as day. A 0.5 centimeter irregular hypoechoic mass at 4 o'clock. It pops right out against the background.
And that turned out to be invasive ductal carcinoma.
Luminal A subtype, the quiet cancer that could have sat there growing for another year or 2 until the next mammogram.
So biologically, these were relevant cancers. They weren't just low-grade DCIS.
Correct. In fact, most of the cancers detected by mammography alone were DCIS,
calcifications, which we know ultrasound struggles with. But the ABIS-only finds were invasive.
That tracks with the physics. Mammography wins on calcs, ultrasound wins on small masses in tissue. But let's talk about the false positives again. We mentioned the recall rate doubled. What about biopsies?
The biopsy rate did creep up. It went from 1.3% with mammography alone to 1.8% with the combination.
And the PPV3, the positive predictive value of biopsy?
It dropped. PPV3 was 59% for mammography alone, but fell to 49% for the combined method.
So about half the biopsies triggered by the combo turned out to be benign.
Which is actually not terrible. I mean, a PPV of nearly 50% is still very respectable in the screening world. In the US, benchmarks are often lower, sometimes around 20 to 30%.
True, these Korean radiologists seem to have very high thresholds or very good eyes. A 59% PPV3 on mammography is stellar.
It speaks to the quality of the baseline screening. But the drop is real. You are biopsying more fibroadenomas or complicated cysts to find those extra 1.1 cancers.
Let's zoom out a bit. We have a study showing that in scattered density breasts, ABIS adds value, but this was done in Korea. Can we generalize this to a Western population or a global population?
That's a crucial limitation. The authors note that Asian women tend to have smaller breast volumes and higher density on average compared to Western populations.
Although these were specifically non-dense breasts.
True, but even within non-dense, the distribution of tissue in a smaller breast volume might make ABIS more effective or easier to interpret than in a very large, fatty breast where scanning takes longer and depth physics become an issue.
Also, the prevalence of cancer in this cohort. 26 cancers out of roughly 1,600 women, that's about a 1.5% cancer rate.
Which is high for a general screening population. It suggests this might be an enriched cohort, perhaps due to the tertiary setting. Samsung Medical Center is a major referral hub.
So we might be looking at a population that is already at slightly higher risk, even if they were asymptomatic. Did they look at risk factors?
They did. About 19% of the cancer patients had risk factors, compared to only 4% of the non-cancer patients. So risk stratification matters.
This brings me to the so what. The authors conclude that supplemental ABIS improved detection, but should we be doing it?
They are careful not to say screen everyone. They explicitly state that ABIS benefits are primarily observed in scattered fibroglandular density.
So no one is suggesting we start scanning every BI-RADS A patient.
Definitely not. That would be waste. But for BI-RADS B, it opens the door to a more personalized approach. Maybe if you have scattered density plus intermediate risk, like family history or personal history of high-risk lesions, ABIS becomes a viable option.
It moves us away from the binary dense versus not dense toggle for ultrasound. It becomes a spectrum.
Exactly. The field used to think of density as a cliff. You're either dense and you get the extra scan, or you're not and you don't. This data suggests it's more of a slope.
But we have to talk about the cost benefit. Finding 1.1 extra cancers per 1,000 exams, is that worth the equipment cost, the technologist time, the radiologist reading time, and the false positives?
That is the million-dollar question, or potentially the billion-dollar question if implemented at population scale. The study doesn't do a health economic analysis.
And ABIS isn't fast. The scan itself takes time, and reading a 3D volume is not like glancing at a 2D image. It takes minutes.
The authors mentioned that ABIS reduces operator dependence compared to handheld, which is true. A tech can acquire it, but the radiologist still has to scroll through hundreds of slices.
Right. If you're adding 5 to 10 minutes of read time per patient to find one cancer in 1,000, that's a hard sell for a strained healthcare system.
It is, unless artificial intelligence comes into play to speed up that reading time.
The inevitable AI pivot. But this paper didn't use AI for detection, right?
No, this was human interpretation, but you can see where the workflow is heading. If AI can pre-screen the ABIS volumes and flag the regions of interest, maybe finding that 0.5 centimeter mass becomes feasible without the time penalty.
That would be the dream. But based strictly on this paper relying on human readers, it feels like a niche application.
Niche, perhaps, but for the woman with that 0.5 centimeter invasive cancer, it wasn't a niche. It was a stage T1N0 diagnosis instead of T2 or node positive a year later.
Absolutely. The clinical relevance of finding invasive node-negative disease is undeniable. It saves chemotherapy, maybe saves axillary dissection.
One other thing regarding the comparison to other modalities, they mentioned the JSTART trial.
The big Japanese study.
Right. JSTART showed that handheld ultrasound increased sensitivity in women with dense breasts. But this study implies that the logic extends to the scattered group, in a way JSTART didn't fully isolate.
And importantly, JSTART used handheld. This uses automated. The reproducibility factor here is better.
Much better. You have a stored data set. You can re-review it. You can track stability over time objectively. Handheld is ephemeral. If you didn't freeze the image, it didn't happen.
True. So to wrap this up, what's the takeaway for the radiologist reading this?
I think the takeaway is don't get complacent with scattered fibroglandular tissue. It is not clear. It can hide invasive pathology.
And if you have a patient with BI-RADS B density and other risk factors who is anxious about sensitivity, adding ABUS is supported by data. It will find more cancer.
But warn them about the false positives. The recall rate will go up.
And don't bother if the breast is fatty. The data is crystal clear on that. No yield.
Zero yield.
I appreciate the honesty of the zero. Sometimes negative data is the most useful data we have.
It stops us from doing useless things.
Precisely. One final thought on the limitations. Retrospective, single country, 2 centers. We need to see this replicated prospectively in a more diverse population.
Agreed. But as a signal, it's a strong one. We need to rethink the non-dense label. It's too broad.
Scattered is the new dense light.
I like that. Dense light.
We'll verify if that catches on. Thanks for diving into the tables with us.
Always a pleasure to find the hidden numbers.
And thanks to you for listening. Keep your eyes on those scattered densities, and we'll catch you next time on SummaryCast.
See you then.